And good to have you this afternoon. I'm Andrew Chamagero. Now, through the new National Strategic Plan 2020 and 2021, going further to 2024 to 2025, the National TB and Leprosy Program is meant to address the persisting challenges with the TB in Uganda. Especially, the goal of the NSP is to reduce the TB incidence by 20%. To achieve this, the NTL will focus on strengthening community systems with a focus on reaching high-risk populations and scaling up TB preventive therapy, enhancing the public-private collaboration, improving diagnostic and treatment services. Now, this will include the adoption of the new technologies and medicines, supporting information management, including digital technologies, strengthening supply chain management, and increasing leadership, accountability, multi-sectoral collaboration, and resource mobilization for TB. To bring this conversation home, in studios with me, I have Dr. Joshua Muhomuza, a public-private mixer officer from the National TB and Leprosy Program. And this program is powered by Uganet and TASU in partnership with the Ministry of Health. Be a part of this conversation on the digital platforms, that is Twitter and Facebook and YouTube, that is NTV Uganda. I'll pick some of your feedback later. Good to have you, Dr. Joshua.
Good afternoon, Andrew.
And it's good that you're talking about TB. To a layman, TB has been on the silence. It has been on the low. I think until recent, when Baby Cool started to come out and, drum about it, people had taken it a little bit more in a laissez-faire mode. How bad is TB, and why should we be concerned about TB?
And now, TB is a condition that has actually been around for quite a while.
Yeah.
I know people tend to associate TB with HIV, and very, very true. These tend to move hand in hand in quite a number of people.
Yeah.
But these conditions have actually been around for quite a while now. Like you said, people haven't paid so much attention to it, and this is actually something we're trying to fight now, because we are trying to reach out to the people to try and paint the picture of how big this condition is. And according to, I'm going to quote the World Health Organization data, it states that Uganda up to now is still among the 30 high-burden TB HIV countries. And if you're to look at the burden just here within Uganda, it's quite high. It's quite high. As of data per last year, we're looking at about 90,000 people that were diagnosed with TB. That puts it at about 260 new cases per day. So it is still a very, very big thing for us, despite the fight.
When you talk about the 30% burden, what do you mean, the burden of TB?
So what I mean by being among the 30 high-burden countries, we are considered among the countries that have TB. The burden in Uganda is actually quite high.
Okay.
It is quite high. And when you look at our incidence, with the National Strategic Plan, it was putting it at about 200 per 100,000. But over the course of the last year, we've managed to bring it down slightly to 196 per 100,000 population, which is still quite big. But as per the National Strategic Plan for the year 2020-2021 to 2024-2025, we are looking and aiming to bring it down by 20%, so that would put us at about 160 per 100,000 people.
Wow. So when we look at this country, I love when you refer to data. I love data. This is music to my ears. When we talk about the high-risk areas,
yes,
where are the high-risk areas in Uganda for TB contact or infections?
So when we talk about high risk, we usually want to classify the people. But I will start off by making a comment that each and every one of us is actually at risk of picking up TB.
Hey.
Each and every one of us, whether you're fully healthy, whether you've had a condition that has placed you into a compromise of your immunity system, irrespective of whatever part of the society we fall under, we're all at risk of picking up TB. But we have a certain category of are people that have a higher chance or at more risk of picking up the TB. And these include the people who are living with HIV. We worry so much about them because once they pick up the TB, it's very easy for them to pick it up.
Yeah.
And the other thing is that once they pick it up, it can come in with more severe consequences. And then the other people we look at are contacts of people who have been diagnosed with active TB. Because TB is an airborne infection. We spread it through the droplets. Once you're very close, once we are close to these people, we are household contacts, there's a very high chance that we're actually going to pick it up. So these are also people who are very at high risk. And the other people are people who are living in prisons or crowded areas, prisons and the other penitentiary institutions. We're looking at subpopulations that have structural risks.
Slums.
We're looking at slums, we are looking at the refugee camps, we are looking at the IDPs. So once we look at areas where we expect to find so many of these people, then those become our hotspots.
Wow. Dr. Joshua, you've used the word active TB.
Yes.
Do we have active TB and inactive TB? If so, please break it down for us to understand it better.
Yes, we do have active TB. And like you've put it, inactive TB, or what we refer to as the latent TB infection. Now, under active TB, a person has been exposed to the TB bacteria. TB is caused by a bacteria called mycobacteria, tuberculosis. So someone has been exposed to the bacteria, and the moment it gets into the body, it's going to create, let me call it a reaction, and it's going to progress into the TB disease itself. So these are the people you will find presenting with typical TB symptoms. They'll present with the typical TB symptoms. Unlike latent TB, now in latent TB, someone has still been exposed to the TB bacteria, but it's probably in small quantities, or the body has a very strong immunity, so it's actually able to fight it off. Now, these are people you will find walking around with the TB bacteria within the body,
but they don't know.
It's actually not displaying any symptoms, and this is quite common.
Oh,
this is quite common.
So that means each one of us needs to go and have a TB test.
Yes.
Because if there is latent, I could actually have TB and I don't know.
Yes, it's actually very, very advisable to have a TB screen, both for latent TB
and active TB.
And active TB.
But is it affordable for the people, Joshua?
For the active TB or the latent?
Both screenings.
Both.
Are they affordable?
Now, screening is actually something that can even be done by you.
Oh.
It can be done by you. Screening is basically making an assessment of whether you're at risk of having TB or not.
How do I do that?
So it can happen at different levels. It can happen in the community, it can happen within the public or the private health facility. So how do you know? We'll start there, that there's a possibility that I could have TB. So one of the things is to actually know the signs and the symptoms of TB.
That's why we dive in. What are those signs and symptoms, Kwanzaa? Because many of us travel for burials.
Yes.
We go for weddings.
Yes.
And much as we've been in the case of wearing masks in the recent past, people are going back to normalcy of not wearing masks and all. It's only you guys in the medical practice that know what we're fighting with. But for us, with the Bantuba ones, we are back to normal. So we interact freely so much with people. And what are some of these symptoms we need to look out for, that we get to know that, oh, I need to actually get medication, I need to get a screening?
Okay. So we have 4 cardinal symptoms. 4 cardinal symptoms. And these are very common with active TB disease. And the commonest symptom we get to see is a cough. And for the healthy, non-immune compromised people,
is that cough unique in its revelation? Is it a normal cough, or it's just a unique cough?
It will actually present like a normal cough. In most instances, it will have a bit of heavy sputum.
Okay.
But for people who are healthy, or for the majority of people, we want to put a timeline and say for a cough that has persisted for more than 2 weeks. Yes, but for the people that are living with HIV, or the people that we tend to say are immune compromised, any cough should trigger a suspicion of TB. Yes. The other things, looking at fever, still looking at a duration of about 2 weeks. We're looking at things like weight loss or poor weight gain among the children. So once we make an assessment of some of these things, maybe the other thing is drenching night sweats. You find someone is having extreme sweating in the night. Those are the 4 cardinal symptoms. We tend to start to suspect that there is possibly a chance you have TB. So once you are experiencing any of these symptoms, you're already doing a self-assessment.
Oh, you get
head to the hospital. Yes, head to a health facility. They will get to do a full screening, and then the screening could also involve other things like a chest X-ray. Yes, they get to do a chest X-ray.
But do all clinics around the country, can all clinics around the country screen for TB?
Yes, actually. All clinics around the country can screen for TB. The only challenge will be in the level of screening. Like I said, we can have the symptomatic or the symptom screen, but we are also trying to emphasize a screening using a chest X-ray for where this is available. So not every facility probably has an X-ray. So for the ones that do not have an X-ray, we can go ahead and do the symptomatic screen. Wow. The ones that do have the X-ray, please go ahead and do both.
Well, I think it comes back to us that all of us need to have a test of TB. We need to have a screening of TB. As a country, this is the only way we can actually fight against TB conclusively, and we bring this home. Dr. Joshua, I want to understand what part of the burden has been contributed by the private sector in the fight against TB?
Okay, so the data I had quoted earlier is looking at Uganda as a whole. There are 196 incidents as of the last year per 100,000 people. But the contribution of the private sector is very, very significant in this. Okay. From still, I love to quote data, like you said. It's only about 20% a notification of TB patients that's coming in from the private sector, which is a bit of a challenge. We want the private sector to be able to be as active as the public sector, yes. And this has been a very, very big challenge, considering that about 58% of people that have been diagnosed with TB have their initial exposure or initial visit to a private health facility. So the fact that the 58% are being missed out on the first case is a bit of a challenge, because once we miss it out initially, it is gone. It is not necessarily gone, but it's going to delay the process. It's going to delay the screening process. It's going to delay the diagnosis. Once it delays the diagnosis, that means the people are still going to be within the community. So we're going to have a continuous spread. The infection gets bigger. Yes, it keeps getting bigger. But if we are able to pick it up as early as possible, then it makes management and treatment very timely. So it also cuts down on the cycle of spread.
Let's talk about the treatment and the management. These conversations about tuberculosis, what many of you call TB. Dr. Joshua, let's talk about treatment. People fear treatment of TB because of its space of treatment. They're close to 2 quarters of the year. Someone under treatment. I want you to break it down for us as Ugandans. What kind of treatment is this, and does it have dire effects on us? One of the symptoms you say the weight loss, and some people when they get on these drugs they really get thin, and it worries us, the community. That's why communities are easy to stigmatize them with maybe someone is infected with HIV, which is something very wrong. But again, what are the effects of the medication, if there is? And someone with latent TB, is his medication far different from the one who has active TB?
Okay. So with advances in technology, in medicine, we believe in something called evidence-based medicine. Treatment keeps changing. New innovations keep coming up. I remember when, during the earlier days, TB treatment was about 8 months initially.
They had big tins of tablets.
Yes, they had very, very big tins of tablets.
Yeah.
And then the drug resistant would push to about 24 months or longer, depending on how you adhere to treatment. But with the new innovations that keep coming in, the treatment duration keeps getting shorter and shorter. Currently, as Uganda, we are practicing one where we take treatment for 6 months. That is for the drug susceptible, the one that is not resistant to the treatment. But WHO is working to come up with something that is shorter than the 6 months. And I am very, very sure in the nearby future it's something that will be rolled out and adopted by Uganda. And this is a duration that is coming down to as low as 4 months. As low as 4 months. And then with coming up of fixed dose combinations, some of the drugs are being combined in a safe way, minimizes the number of tablets that the patients actually have to take. Yes, so treatment is getting a little bit easier now in a way of trying to promote adherence. We want people to take the treatment without not so much of a struggle. We want people to be able to complete their treatment, because that is one of the objectives of the current national strategic plan. We want as much as more than 90% of the people that are taking TB treatment to be able to complete it.
Are there effects,
to be
doctor?
able to complete it.
Because why I'm asking that, men have poor medical seeking habits.
True.
And men, good thing we're here as men, we tend to we are hard guys. Until the last day when you get on the edge and you say, okay, now I can go to the medical facility. But when it's too late,
true.
Are there daring effects?
And now, like every drug we take, every drug has side effects.
Indeed.
But the beauty with evidence-based medicine or things that have actually been tried out with evidence is you're able to, in most cases, anticipate what is going to happen. Now, with the TB drugs, they've actually been studied. So each particular drug, you have anticipated side effects, which will not happen with everyone. The majority of the people are going to take them and they won't have any issues. There are those few that will take them and they will have the issues. But as part of the treatment, you get to explain to each and every client you encounter what the expected side effects are, so that in case they happen to see them at any point, they know when to report and when not to worry, because some of the side effects will come and just pass. And then there are those that have to actually be reported so that we can see if there is a possibility of switching
the drug.
The drug, yes.
I hear you. Let's go back a little bit in the private sector. What are some of the challenges the private sector is facing in combating TB as a disease in this country? Because there are challenges that we shouldn't actually run away from.
So we still believe the private sector is very, very key.
Yeah.
But we've had a few challenges, and these challenges mainly stem within the private sector itself, because most of the emphasis has been placed on management of TB in the public. So we are now trying to address some of these challenges in the private sector. And the biggest challenges we tend to see, I'll mention maybe about 4. One is a knowledge gap.
Yeah, there is a knowledge gap.
There is a very big knowledge gap where the health workers, yes, they do have a bit of knowledge, or they have knowledge about TB, but the suspicion index is very, very, very low. You will find people are presenting to the hospital. You'll find, actually, I think there's a study that was done in India that put about 30% of people that are going into the outpatient department in a private facility or a public facility, about 30% of them present with symptoms to do with the chest, a bit of cough and all that. Unfortunately, the suspicion index is very, very, very low, in that you will find managing you for a cough, upper respiratory tract infection. Move from one hospital to another, my cough is not getting any better. Reach there, they'll tell you maybe it's this, maybe it's this. By the time we sit down to actually think of TB,
it's too late.
It's actually been on for quite a while. And then still to do with the knowledge gap. even with the clients,
the people who are not
yes,
informed.
the people out are not informed, and that has actually been one of the things we are trying to do so much as the National TB and Leprosy Control Program, to try and create a sensitization, try and create awareness to the people, because once people do know what TB is, how it's presenting, then they are also able to do a self-assessment. Once they come to hospital, they are able to demand for services that are going to drive in that particular line. And then the other thing is something we mentioned earlier. Not every hospital is able to diagnose, to screen. They may be able to screen, but they're not able to make a diagnosis of the TB. They don't have the X-ray machines. There's a machine that is very, very key in making TB diagnosis called a gene expert. And the fact that not so many of them have it makes it also a little bit hard. You will come in, they may be able to screen, but they're not able to go the further way. Yes, so you find people are being put on just the antibiotics. They're like, go and take a few antibiotics and you'll probably be okay, yes, which is not a good thing. And then the other challenge is in regards to cost. In regards to cost, yes. Making a diagnosis of TB in the private sector is a bit expensive.
Yes, it is.
It's quite expensive. For you to come in, do an X-ray, before you know it, they're telling you have to do a gene expert now. Hospitals are charging close to 300, 400,000.
Should I tell you what?
Yes.
I'm a typical Ugandan. The moment they tell you have to see an expert, you hear word specialist, expert, what rings in your bell? It's money. Because the language medical practitioners use in a way pushes us from, seeking medical attention when the time is still due. Because you're like, now they have done the screening, they say need to be referred to Genex, you say? And that's around 300,000 Ugandan shillings. In today's economy, someone will think and say, let me be taking maybe herbs for lack of better alternative solutions, and they'll end up there. But again, doctor, I wanted you to dive a little bit into it with part of the reason as to why the populace, we are not as sensitive to TB as it should be. Do you think culture meets and beliefs in a way have sabotaged the conversation on the ground?
Yes, I do believe that. And culture is very, 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 very key. All the social beliefs are very, very key when it comes to management of any illness. Once people have a particular perception of an illness, it becomes very, very hard for us to change it. Yes. So you'll find that people who believe TB is totally related to HIV, and that is their belief, which is very, very, very wrong. Right now, actually, we have about 38% TB HIV relation, so it's come down. It's actually come down. So not everyone with TB has HIV. That should be very, very clear.
Wow.
Not everyone with TB has HIV. Actually, the majority of people with TB do not have HIV. But two, there are also people who are going to believe it's cultures that believe it's sort of a possession for you to have severe weight loss and all that. No, it is not. Like every other infection, once we fall sick, the things that are going to take place in the body. We may lose appetite, we won't eat right, and these are things that are going to contribute to the way we are going to appear.
Now that takes me back to the private sector. Is TB management far different from how it's managed in the public institutions, and how?
It's actually not different.
Okay.
It is not different. The treatment we use in the public sector is the same treatment that should be used in the private sector. The same way we screen for TB in the private should be the same way in the public. It's basically a standard. It's a standard. So once we use the anti-TB side, it's the same thing the other side. The dose is the same. The duration of treatment is the same. Yes, so it shouldn't differ.
Now, we have an information gap even among the healthy service providers. What are you doing as an entity to make sure that that knowledge gap is covered, that even the doctors or the medical practitioners are going to find on the other side, they're grounded with accurate and timely information. Because someone could be a nurse for the last 20 years, he has not, or she has not gone back for a refresher course about the new dynamics of how the virus and the bacteria plays. What are you doing about that, and what sequence are you using to train them better?
So still to do with, I'll go back to the National TB and Leprosy Program and the Ministry of Health. We're coming up with quite a number of strategies to see how to reach out to the private sector, create awareness among the health workers, conduct trainings, conduct mentorships. We're supposed to go and do supervisions to make sure things are actually moving on quite well, because we realize, like you say, people will be in practice for over 20 years and we're not getting any refreshers.
True.
So these are some of the things we are trying to look out for. Make sure we are feeding people with information. Try and conduct a continuous medical educations among the health workers. Try and engage them, provide them with information material so that we try to keep them up to date as much as possible. And the other thing the program has come up with is what we call a public-private mix, a technical working committee. And this is supposed to spearhead the infiltration of the private sector. So it's supposed to have stakeholders that are going to come in from the private sector, yes, so that they are also actively involved in making of decisions, discussions, review of reports that are actually affecting the private sector. So it's quite a number of things to try and incorporate the private sector into this fight of TB.
The conversation is about TB. On Twitter, drop me your feedback and drop your questions. Dr. Joshua will be here to respond to that, and I'll take a break for now, and when I return, much of this conversation is coming. Remember, this program is powered by Uganet, TASO, and in partnership with the Ministry of Health. Return short. It's powered by Uganet and TASO Uganda in partnership with the Ministry of Health. I'm Andrew Chamagero, and in studio I have Dr. Joshua. You're talking about TB. Dr. Joshua, before we went for the break, we wanted to tap into the deeper end, the issue of prevention. So how do I prevent myself from, getting infected with TB?
So prevention of TB comes at different stages. One of them is still, like I say, raising awareness. We are communicating to the community. We want them to know at what point do I start to suspect that I could probably be having TB. And when you find out, it's going to quicken the treatment or the care cascade. We are going to get our diagnosis made timely. We're going to start treatment in time. So this is going to help us protect at least the people that are close to us. But there is also what we call TB preventive therapy or treatment for people that are at high risk of picking up a TB. And once we realize we are at high risk, or once we meet the criteria for being at high risk for picking up TB, we can actually start the preventive treatment or the preventive therapy. And the beauty with it is the duration, or the duration is actually shorter.
Oh, shorter, of the preventive?
Yes, of the preventive.
Okay.
We currently have one that is going on, a program that is going on, and it looks at treatment. You take treatment once weekly.
Oh. Yes,
once weekly for about 3 months, and that is protective enough.
Is it free?
For now, yes. In the hospitals that
nice.
Accredited to give it out, especially the private sector, sorry, the public sector. It is free of charge once you fall under that category that is eligible for that, yes.
I have a wife, and she is positive with TB. She has active TB. How do I make sure that I'm not infected, but I still treat her without stigmatizing her?
Now with
that's a hard one. I got you there, Josh.
it is a hard one. It's the same challenge we're actually facing with
yes, because
with
I mean with COVID very much so, because she interacts with me, she talks to me, she can't wear the mask 24/7, and she's my wife, and she was exposed at that.
So it's a bit of a trick at that particular point, and would make 2 recommendations. One is to be patient with her, try and be as supportive as possible, because management of TB is not all about the taking of medication. It comes with quite a number of support structures, yes. And then 2 is still advice to Madame here. We want her to try and be as protective as possible. Wear a mask. For now, it's what we recommend. But this is not for the entire duration of treatment, because we usually look at the first 2 weeks of treatment as being the highly infectious. Usually after 2 weeks post-treatment, we are not as infectious as we would have been if we were not on treatment. Yes, so going forward, we don't worry too much. And this also applies to people that we refer to as the PBCs, the people who have the bacteriologically confirmed. We've done the gene expert and all that, and we do have TB, because these are the people that are at the highest risk of spreading it. But the other bit, then we don't need to worry. After that, you can resume. These are still human beings. We do not want to stigmatize them. It's the biggest thing that we are fighting. And we want to try and be as supportive
as we can.
That
was option 1. Option 2?
Option 2, I actually mentioned 2 options. One is...
So is it okay for me to take preventive medication when my wife is on her active medication for TB?
Yes. Because this is a household contact. This is a household contact of a TB, especially if it's bacteriologically confirmed. We actually have to take the preventive treatment. It's actually one of the things we are looking at so much right now, that each time we do, there's something we call contact tracing, in that once a diagnosis of TB is made with a member or an index member of a community or a household, we want to look at the people that are closest to that particular person. When we get to them, we do a screening amongst them, see if there's a possibility that they've actually developed the TB, the active TB disease as well, or not. If they've developed the active TB disease, then we'd have to start them on treatment. And if they haven't developed the TB, then we'd have to go ahead and put them on the TB preventive
drug. That makes sense. Yes. Let's talk about stigma. When you go to public institutions, the people with TB are given a particular line and should I call it a corridor, that that side is for those of TB. In a way, there is a way it brings stigma, like at the word go. You arrive and you're with TB, you're like an outcast of sort. Coming to the private sector, how are you dealing with stigma? So stigma is still a very big challenge in the private sector, and stigma basically sources from people not knowing. It's a knowledge gap. So one of the things that are being tackled is trying to raise as much awareness as possible to see how to make people know that TB is actually not a death sentence. It is not a death sentence. Once you do the right things in the right way, then you're going to get cured. We're going to cut down on the transmission. And in the private sector, it's going to be as it is in the public sector. In that once a diagnosis of TB is made for anyone, we try to support them with all the social structures that we can. Treatment wise, in forms of follow-up to ensure adherence. We're looking at a patient-centered strategy. Patient-centered strategy where you're putting into consideration the patient's needs, where they stay, to see if you can actually deliver treatment to them. You try to involve the family in this management, try and get them in touch with people that have actually survived the TB themselves, because these are going to offer hope. They are basically a source of hope. So as we approach the stigma, we still clearly want to state it. That TB is not a death sentence. It's
TB
curable.
is curable. It can be treated and cured. And cured, yes. So it is very, very key.
That gives us hope. There is an issue of inclusion of the PWDs. What is the private sector doing about it with those with impairments, maybe hearing, maybe sight? maybe others are lame, and these services or the drugs are not easily accessible given their nature. How are you addressing this as private sector?
So the coming in of COVID highlighted quite a number of challenges within the way we were providing care to people.
It exposed us.
It exposed us.
Yeah, very much.
It did expose us, but the exposure also caused us to think a lot on how we're going to have continuous service delivery to people despite the different barriers that were actually in place. And the care right now that is being offered, like I told you, is patient-centered. We try to look at quite a number of needs that are affecting, or we look at the things that are surrounding the patient. We want to do everything, and everything we do should be tailored to meeting the needs of the patient. Yes. So if they're in a position where they can't access the hospital, we want to see, is there anywhere we can actually reach out to them? There's new technology coming in. We're now looking at digital adherence technology, whereby the patient is at home, they're taking their medicine, but you as a health worker can actually still monitor and make sure they are adhering to this treatment.
Okay, that makes sense. But let's talk about the non-medical sector. How do we support people with the TB?
The non-medical sector. Now, this also has a very big role to play in TB management.
Yes.
And the reason as to why I say that is TB is a community diagnosis. It is something that is affecting the community. You're not going to only find it with one person. And when you look at the private sector and its setting, we are workers. You're going to find people in factories, areas of crowding. You're going to find students in school, very, very crowded. So the private sector actually, private non-health sector, has a very, very big role to play in all this. We are trying to make sure that we incorporate the TB policy into our work setting. We've seen how HIV has been incorporated. The HIV policy has been incorporated into the work setting, and this actually helps build awareness. People get to ask. We want to get to a point where at least the private sector is able to have screening of its people. It could be once a year that the workers and the employees are screened for TB. These are things that are going to help us clear it out of the system of the country. But we also look at the private sector in terms of support. This is something that is a very, very expensive, like we stated initially. It's a very big burden on the government. And for now, we would take as much support as needed. Yes, it can be financial, it can be through campaigns. We are currently having one here where we are talking to the people and creating awareness. So these are all things that we actually look out for in fighting TB.
Let's talk about the drug resistance, Doctor. What brings the drug resistance?
Now, drug resistance comes about as a result of something we call a mutation. Mutation is a change in the structure of this bacteria. And maybe to explain it better, let me give an example of why mutations come about, especially in TB, and then I can give an example for everyone else to try and get it. Now, things that are going to contribute to changes or to resistance, things like insufficient dosing. We are giving a person a dose that is not sufficient for their weight, because most of these TB drugs are given according to someone's weight. We're taking treatment for a very short course. Someone has taken for a month, and then they suddenly decide to give up because maybe they're feeling better. We have people
maybe there is no stock anymore.
Yes, there is no stock anymore, so you can't go on. So these are things that are actually going to contribute to these bacteria resisting the treatment. Once you're not giving them the sufficient dose to kill them, they learn how to survive. They learn how to survive. And I have a friend of mine who always explains it in terms of a key and a padlock. That every padlock has a particular key to it. Yes. And if you keep bringing different keys and playing around with this padlock, there's a point you will get to, and this padlock won't open even with its original key, because things have been messed up in there, things have changed, the structure in there has changed, and that is how drug resistance builds up. We have a change in the structure of these bacteria. They tend to get a bit superior to our medicine.
So how do we help the countrymen to adhere to the medication? What is our call to action as citizens to help our relatives, our wives, our children, our parents to adhere to the medication?
One is to clearly come out and tell them that once we adhere to medication, TB is curable. We will take it and we will cure. We will cure. And then two is support. We need very, very good support for these people. We have to be around them. I remember back then we used to have issues of drinking on a cup of someone who has had TB or sleeping in the same bed or things like that. And these were myths. They were myths. So we try to embrace them as much as possible, try to be close to them, try and offer as much support as we can. We've seen employers who are terminating contracts of people because they've been diagnosed with TB. They're sending them away on indefinite leaves, which is not right. Which is not right. People who have TB are still part of us. Once we take our treatment right, it is something that we can fight. But also the ministry is coming up with quite a number of other innovations to try and help the people adhere. I mentioned something called the digital adherence technology, where you're able to reach out to people without actually having to be there. There are SMSs with information and monitoring being sent to people. The older bit of this digital one was the directly observed treatment or therapy, where you had to train people that were close to the patient to try and be there with them every day, monitor them, take the treatment. Yes, directly observe.
When we come to the issue of information dissemination, can we dig a little bit deeper? What platforms do people have where they can go to get adequate and timely information? Because there could be information that is distorted, and some of the information comes, but when it's not timely, like it's either too late or it's off the chain, that they can make use of that data. Do you have platforms where they can find this information, or when they go to facilities, be it private sector or public institutions, where they can ably go and ask information about TB and they're not judged whatsoever the case?
So one of the things we're trying to do with the private sector, I'm going to quote the private sector now, is to try and push for creating awareness or sensitization. And this is through putting up of educative information or
those posters used to be there. I don't know what happened.
Are very, very key. Put up such things. We are trying to come up with drives to sensitize people about all this. They're trying to come
Actually,
up
you
with,
had vans that used to go to schools. I remember in Chihuahua there, way back in the early 90s, they would come and put it at a church, and they would teach us about TB and how it goes around. Even they would put these posters to the churches and the mosques.
Yes, the trucks are actually still there. We have some very, very big trucks that are carrying out campaigns, and they're very, very well labeled. But we're also looking at ways of how we can reach out to more people, maybe through educative information in the travel sector, in the transport sector, in the buses, the TVs, public services, or the public facilities, the health facilities. See how to pin up posters. We're trying to make sure at least they're everywhere where people tend to gather. Where people tend to gather, but also as a way of people wanting to know on their own. We advise forums that are legitimate, let me say
because that's the thing. People are going to Google.
People are going to Google, they're going to go to WhatsApp and see things that
Google
are moving around. But there are official pages. Let me say, for even an example of the Ministry of Health has an official page. So you can actually go there and see what is being spoken about. We have support partners, the TASOs, we have the IDIs. The pages actually have very, very educative information. And then the Ministry of Health portal online. We should make use of it. It's very, very accessible. very accessible.
That's very good.
Has very good information.
So, countrymen, the conversation we are having as well, finalizing this conversation, it's about you and I to go to a health facility and get tested for TB. The screening of TB is very critical. All of us, as doctor says, we are susceptible to having TB within us, but when it's just latent, it's not active, but it could be there. And those who are actually having TB, these are some of the symptoms: heavy cough that could last for more than 2 weeks, fever that could last for more than 2 weeks, it comes, it goes, then weight loss and extreme sweat in the night. When profusely sweat in the night, that should be one of the red flags to show that you should possibly check with a medical facility just to check up for TB. Doctor, as we're finalizing this conversation, what is your advice to people who are on TB drugs, but they keep taking a lot of alcohol and cigarettes?
Now, this is a very, very big challenge.
Yeah.
And at the start of the show, I remember we mentioned people that are at the highest risk.
High risk, yes.
Yes, that are high risk. And alcohol or tobacco consumption, the two of them tend to also increase your risk of actually picking up TB. Your body won't be able to fight very well. But also once the TB sets in, the chances of it knocking you out are very harsh, or the chances are high. And when we look at the two organs that these two things affect, alcohol is going to affect your liver the most. It's going to affect your liver, and yet the liver is very important in the breakdown of some of its drugs. So it's totally a negative. You're doing yourself a disservice. Same thing with the tobacco. It's going to affect your lungs. TB is still going to be in the lungs, so you're basically having a double attack on your system. So these are things we need to try and avoid as much as possible. Yes, we need to take our health very seriously.
Well, Doctor, the conversation seems to be very interesting, but we have to come to an end of this conversation. What are your parting shots to the countrymen? And these drives you're saying that are currently ongoing from the private sector and the Ministry of Health about TB, where do we find them? And is it at the parish level? Is it at the district? Is it at the sub-county? Or are they coming in our villages? And how do they look like so that we can identify them as citizens?
So my parting shots. One is TB is real.
True.
TB is very real. And it is a disease or an infection that can affect anyone, anywhere within the society. That is one thing we have to know. It's not something that is limited to only people with HIV. It can affect anyone. Immune compromised, the diabetics, people with cancer treatment or dialysis. So we have to be even the healthy people, you can actually pick up TB. So we have to take extra precaution. Get yourself screened once you happen to notice that you could have a symptom of TB. And then two is we're trying to create awareness. So there are campaigns that are going on. In September, we have one that is coming up. It's called a CAST campaign, where we will be reaching out to different communities to do awareness, create awareness, screen for TB. Those that are found positive will have to be started on treatment. And then those that actually meet criteria or are eligible for the preventive treatment get to have a treatment. The structure of the Ministry of Health, especially in regards to TB management, is quite broad. So people will be reaching out. We have people who at the program overseeing everything. We have regional supervisors. We have the district supervisors. And then one thing we are pushing for in the private sector is for at least every private facility to have a TB focal person.
That would be nice.
A TB focal person, yes. So that these are people that are giving out the information. They are the people that are monitoring and tracking these people who have been diagnosed with TB to try and make everything more accessible for people, to try and make treatment and management of TB a success.
That is a great conversation, and Doctor, we really want to thank you for the time you've given us. We really want to thank you for the conversation. And I can assure you, Ugandans are going to take actions about this. Countrymen, the onus is then on us. You need to go and have a TB screen. I, for one, am going for TB screening because now I understand that all of us, you know, have big chances of having TB, and it could be silent. But we need to go and have these tests and screening, and just to get to know how to deal with it in time. Remember, TB is curable, and if not cured well or in time or captured early, it can kill you. So be very, very vigilant while you're having all this information around you. If you have this information and there is a friend, a colleague, a community leader, or a community citizen who possibly has the symptoms of TB, kindly reach out to them and let them go have a screening. And after that, let them start the rightful medication. Your job as a countryman then is to support them through. Don't stigmatize them, because even you, one day at a time, possibly you could be in their space. So give them the support they need, and thereafter we can build a resilient country. This program was powered by UganAid with Ataso Uganda in partnership with the Ministry of Health. I'm Andrew Chamagero. Good afternoon.